Welcome to the center. A lot of familiar faces, maybe a few people I don't know, but if you haven't been here before, welcome to the Documentary Center. Our talk is called Series. Very pleased to have introduced a brief introduction to Diane Wach, who will talk today about a very interesting topic. We in the center, one of the issues that we deal with or want to study is the whole research to practice, research to policy kind of research translation process. And Diane today I was going to talk about a kind of interesting kind of case study of that, having to do with psychological debriefing as a practice or program or intervention, and how research kind of fits into that. I mean, we think sometimes the research, doing the research, developing a practice or a program, testing it and implementing it is a nice, rational, kind of left-away process. In reality, it often doesn't work that way. There's lots of programs and practices that get started that the research then follows afterwards and may or may not report the efficacy of that, or there's some good research back then, but then the research changes and the behavior about all those programs that are in the field that you started. So it can be a really messy kind of process, the whole research to practice process. And Diane's going to talk about a kind of case example in this regard. I'll tell you a little bit about Diane. She has a few hats she wears, as you point out. She's a research support specialist within the center within the Data Archive on Child Abuse and Neglect, which she does great work. At the same time of doing that work, she's a graduate student in human development, so she's trying to continue her doctoral degree along the way while still working, and that's a real challenge, and give her a lot of credit for trying to do that. But her former life, as I said on the announcement, before she came to Cornell, she's a licensed therapist, and she worked in the Washington, D.C. area, where she treated lots of different kinds of clients, including people who had undergone traumatic situations. She was there during the Washington, D.C. sniper incident and saw people after that, after September 11th. So she has some clinical experience as well, treating people with traumatic PTSD and exposure to trauma. So she has that experience as well as coming at this from a research perspective. So given that, I will turn it over to Diane and thank her for taking us through the presentation.
Thank you very much, John. We're going to talk about today our competing perspectives of research and practice, a case study in trauma debriefing. And the case study I want to talk about is critical incident stress management, or critical incident stress debriefing. And what I'm wondering, first of all, and thank you all for coming in. I see lots of friends and lots of new faces. But by a show of hands, how many of you are clinicians here? Okay. And how many of you are familiar with or have done critical incident stress debriefing? And I have also, for many years I did. I want to talk about critical incident stress debriefing as case study. We'll go through the description of it and the definitions that are related, and then talk about it within a translational research framework. And I'm going to go through the history of this case. And talk about areas of controversy and points on both sides of the debate around this intervention. And then we can reflect on the process of translational research and what we can learn in particular from this case. So, to start off with the definitions, like I said, I just want to define trauma as a diagnostic of physical mental disorder says right now. It's any event that causes death, serious injury, loss of physical integrity, or spread of or witness to any of these. Examples are war, crime, sexual assault, accident, natural disaster, child maltreatment. In the context of this intervention, trauma would usually be referred to as a critical incident, and perception and interpretation are really important. What may be a trauma to one person or in one context may not be experienced as traumatic to another. Post-traumatic stress disorder is a diagnosis that is preceded by a traumatic event, and for adults, at least, is followed by feelings of fear, helplessness, or horror. For children, the diagnosis can manifest differently. But for adults, there are three clusters of symptoms: re-experiencing, avoidance, and hyperarousal. The re-experiencing is just not being able to get this event out of my head, intrusive thoughts, nightmares, just the stress over the event. The avoidance symptoms are that maybe you avoid something that reminds you of the trauma, maybe you can't remember aspects of the trauma, you might feel numb or like the world isn't real, or have anhedonia, which is diminished joy or diminished feelings about life. Hyperarousal is just that, just hypervigilance, can be accompanied by paranoia, being irritable, sleep disturbance, problems concentrating, and these sorts of things. 1 to 14% of the public will get PTSD at some point in their life, be diagnosable. As far as after a trauma, the research shows a real range as far as who gets PTSD. Some studies show as low as 3%, some are as high as 58%, depending on the trauma, the people, the circumstances, and so forth. Another important point about PTSD is that people can be diagnosed with symptoms in the first month following the trauma. Some of those symptoms, these same things listed here, are considered normative or can be indicative of another disorder called acute stress disorder. But if the symptoms persist for more than a month, somebody might meet these criteria. And also, 50% of people who experience these symptoms who are diagnosed with PTSD will have full symptom remission within 3 months. And that's just important to keep in mind when considering this intervention. We're going to talk about psychological debriefing. Typically, it's a one-time intervention. That's not always true. But psychological debriefing is sort of the umbrella term that clinical incident stress management fits under. So there are other brands of psychological debriefing as well. The purpose of it is usually to normalize the response to the trauma, to reduce PTSD diagnosis and symptoms, and it's based in the idea that it's beneficial to talk about the trauma immediately following the incident. Now, critical incident stress management falls under psychological debriefing, and this is considered a framework, not a therapy. And there are many steps to this intervention, and it can start with pre-crisis preparation. So for people who work where they know they may encounter traumatic events, like EMTs or first responders, they may do some preparation before ever encountering that situation for themselves. Disaster or large-scale incident response is usually like a town meeting or a large group meeting following a traumatic event. A diffusing is usually an intervention done in a few hours after a trauma. There's a 3-stage process by this model, and by which that is an option. And then critical incident stress debriefing is the intervention we're going to talk about today. A big part of the controversy is that the people who created this say that critical incident stress debriefing can never be done on its own without the rest of this framework. But sometimes that does occur. Steps 5 through 7 here are all sorts of just follow-up, family crisis intervention, referrals for further services and counseling and that sort of thing. So the critical incident stress debriefing component, number 4 here, held the Mitchell model. It was created by Jeffrey Mitchell, and he did some of my training in this model. It's a structured group discussion. If you can imagine, it's usually the way that we used to do it. You would have like a easel whiteboard, and 1 to 10 days post-crisis, we would sit in with a sharp-eyed recounting the facts of the trauma. What happened for you? What happened for you? Can you tell me what you experienced? And we would record all of this for the group. Then we would go into describing the emotions and the thoughts. What were your thoughts? What was the most traumatic part for you? How about for you? What are your reactions? What were your feelings? And then we would talk about if anyone was experiencing any sort of trauma symptoms or any distress because of this. And we would go into teaching and symptom education. And then re-entry is sort of this closure idea. We're finished the intervention, and you're going to go off, and depending on the trauma, people may be going home, or if it were police officers or something, they may be just going back out to work following this. The purpose was to mitigate acute symptoms assess for follow-up needs, and provide closure from that incident. Throughout this presentation, I'd like all of you to think about the stakeholders when it comes to critical incident stress debriefing. There are so many people who have a stake in this, and it's, of course, the participants and their families, but also the people practicing it who are not always clinicians, clinicians who may be doing it or may be referred afterwards, researchers, governments, politicians. There are a lot of people who are invested in this intervention. And I wanted to give you this word, iatrogenic. Some of you will know. Part of what the criticism of critical incident stress debriefing is that it might have negative iatrogenic effects. And what that means is, but for the intervention, maybe people would not be worse off. So there's some negative impact from the intervention with what has been achieved thus. I put these here just because I use them in my presentation. For those of you who are not medical people, diagnosis, history, symptoms, and treatment, these are just abbreviations if you see them throughout. So this is a model of translational research, as John was talking about, this sort of how when we don't just see a problem, create an intervention, and go out and employ it. And Steve Hamilton created this, and I really like it. It shows how all of the aspects of research and practice interact throughout the process of creating an intervention, evaluating that intervention. So if we look at what's happening, what's the situation, what's the problem, what makes them tick, the basic research. So what's the research on trauma? What do we know about trauma? What's the research on stress? What do we know about stress? And how do we bring that to practice? And then creating interventions or prevention, things, what works, then let's evaluate that, back to practice, and how do we use what works, and how do we disseminate that? And so I'd like you all to keep this in mind as well as we go through this. And we will get back to that at the end. So looking at the history, if we go back to Freud, we know he liked to call his patients histrionic and dependent who had been through trauma. That's some of the first ways we identified the impact of trauma on people. World War I, we called it cell shock, war neurosis, or Edwards syndrome for the soldiers who had been through battle. In World War II, a fellow named, look at his name, Samuel Lynn Atwood Marshall. He was a U.S. Army combat historian. And actually, his story is a little controversial as well, but I won't get into that here. If you want to talk to me about it afterwards, let me know. But he created really the first psychological debriefing for combat soldiers. And the point of his psychological debriefing was, we're going to, after a battle, come together, and we're going to talk about what happened in the battle and recount the facts for the military record. And then that's going to bring us some unit cohesion so we can return to battle and be stronger. So moving along, as we were able through time to sort of identify the impact of trauma on our psyches a little better, these are just a few quick examples. There was the Coconut Grove nightclub fire of 1942 in Boston, and Eric Lindemann was an author and psychiatrist at the time, and he wrote in 1944 about the fire. 492 people perished, and he started to see how the community grieved and how this affected the community and how they worked together. And he wrote a book about that. In 1963, Gerald Kaplan came out with the 3 tiers of preventative psychiatry. So instead of just looking at when somebody has an illness, what are we going to do? He said there are really 3 stages, the primary, secondary, and tertiary stages, where in the first one we want to reduce the incidence of the disorder. In the second one we're going to reduce the duration of the disorder or the symptoms. And then in the third one we want to reduce the impairment. And so I bring this up because critical incident stress management strongly identifies with the secondary level. So we want to reduce the duration of the symptoms or of the disorder. And then Burgess and Holcomb in 1974 put a name on the symptoms and experience that many people who've been sexually assaulted have. And this was an important day, I think, in the history of trauma research. 1980 was the banner year. That was the year that the Diagnostic and Statistical Manual of Mental Disorders, third edition, put PTSD in the book as an official mental disorder. And 3 years later, Jeffrey Mitchell developed critical incident stress management. The purpose of it was for emergency personnel following a traumatic work experience to sort through that. And the goal was to prevent or at minimum inhibit PTSD symptoms and stress reactions. Jeffrey Mitchell was an EMT in Maryland, near where I'm from actually, and I read in an interview where he went out one day on a call and saw an atrocious automobile accident. And he had intrusive thoughts, and he couldn't get these images out of his head. And he talked to a friend, I believe it may have even been a relative who was a firefighter, and he felt very much better after that. And it was from this experience that he thought, we need a systematic way for people in this line of work to deal with this trauma that they're going to experience. Shortly thereafter, the U.S. military adopted a modified version of critical incident stress debriefing. And some folks here at the military project may know more about this than I do, but at some point around 2000, I think a little before, I know that they stopped using it. But what I'm reading right now in the literature, it seems like they may be using this or something like it again, and I'm actually not sure where they are in that process. In the 90s is when everything got really busy around critical incident stress management. So in 1996, there was a lawsuit of the Royal Marines versus the United Kingdom. This is a group of soldiers who sued the government because they said, we experienced trauma and you did not provide us psychological debriefing. Mitchell has asserted since then that the government engaged a man named Simon Wesley, he was a professor of psychiatry at King's College. And Mitchell's assertion is that they wanted him to prove that psychological debriefing was not effective so that they would win this lawsuit. So really, this is the crux of where the two sides of this argument really became polarized. As far as, is this a good thing to do or is this not a good thing to do? In 1997, there was the first Cochrane review of debriefing. And the Cochrane collaboration is a group that is a volunteer nonprofit group that does systematic medical reviews with the purpose of trying to identify best practices. And they said, we shouldn't do it. It looks from the studies like there might be these negative iatrogenic effects. What is interesting and what continues to fuel the argument between the sides pro and anti-critical incident stress management is that Simon Wesley was a primary author of that Cochrane review. Then, moving along, 9/11, 2001 is when I was working as a therapist at Montgomery County Crisis Center in Maryland, and we did critical incident stress debriefings quite frequently. And at 9/11, we were right outside DC, so we knew many people who were impacted from that. And a lot of our therapists also went up to New York as therapists from around the country after 9/11. After 9/11, all 55,000 New York police personnel were required to participate in critical incident stress debriefing as a way to help them through what they had been through, and not just officers, all of the personnel. Shortly thereafter, there was a collaborative international review, and some of the participants were the United States Department of Health and Human Services, Department of Defense, Veterans Administration, the Red Cross, and multiple smaller organizations and multiple international organizations. And they came together, they had a meeting, they reviewed all of the literature, and they said, we really need to stop doing interventions with recitals of events and emotions after trauma. They found that it might not be helping people, or not be helping everyone. National Institute of Mental Health also did a review and said stop doing psychological debriefing. And there was a second Cochrane review which said stop doing compulsory debriefing of trauma victims. And then there were other studies that also said maybe we shouldn't be doing this. And in my workplace, it actually polarized my workplace, and half the therapists would do it and half the therapists would not. And that's how we went on. The creators, Mitchell and Everly, the creators of critical incident stress debriefing, conducted their own meta-analysis. One year later, in 2002, which they published, and they said critical incident stress management mitigates stress symptoms. It's working. So they said that these calls to cease are uncalled for, and they saw it as an effective intervention. 2007 is when I got involved in reading and looking at everything I could find on this topic. I saw an article that said the UN was adopting critical incident stress management, and I thought, oh, I didn't know if we were still doing this. I wonder what's going on with that. So then I started looking into it, and the UN adopted it because the staff was saying, hey, we need something. We're seeing these horrible traumatic events. Please provide us some sort of staff support. And they went to the International Critical Incident Stress Foundation and decided to adopt that program. In 2009, there was a third Cochrane review, and again, they said stop doing psychological debriefing. And today, the use has really expanded. It's more generalized. It's being used in communities, being used in the private sector, being used sometimes in schools. There are 1,500 teams worldwide. There are people being trained every day and every year. And teams did go to Katrina after the hurricane. They followed up with people, the Haitian earthquake, and even for Sandy Hook for first responders. There were critical incident stress management teams there. So that sort of brings us to what is the debate? What is this debate all about? On the dark blue side, I'm going to put your pro-CISM arguments, and on the light blue side, we have the anti-argument. So the pro-CISM argument, the strongest one is the argument of faith validity. It's beneficial to talk about a trauma immediately following the incident, right? We all know this. We say we need to process it. They say it's just a conversation. It's not a therapy. We're just talking about what just happened. And we've seen what happens with soldiers when they go untreated, and there's this repressed trauma, and we don't want that to happen, so we should talk about it. The anti-CISM side says, well, we've always thought that, but it seems to be ineffective, and the studies seem to show that there may be these negative antigenic effects in some portion of the people who receive this intervention. So there's been some theories about why would it be bad? How could this be a negative thing? One idea is that maybe it's too soon. We know that cognitive behavioral therapy ameliorates PTSD symptoms, and it's pretty effective. But the idea behind that is we're correcting thoughts, we're correcting cognition. So maybe we shouldn't be correcting cognitions before people have orgasms. The other idea is that maybe it's pathologizing a normal response. So here you've been through something, and now we're telling you you need an intervention. Maybe you shouldn't have an intervention, maybe you should continue with your life and go to your normal support system. A big part of this intervention when it was first started is that it's supposed to bring people a feeling of closure. So there's some theory that maybe participating in this intervention keeps people from going and talking to their grandma or their parents or other people at the would because they think we're finished with this now. It doesn't take into account people's mental health, if they have any mental illness, past experience, or trauma history, because it's usually provided to all. And there's an issue of symptom expectancy, and I find this really interesting because when we used to do it, and I'm pretty sure Mitchell and Everly would say we don't agree with you doing this, but this is a list of common signs and signals of a stress reaction. And we used to give something like this to people, right after the intervention. And it says you might be nausea, you might faint, you might have nightmares, confusion, you might commit antisocial acts, or be pacing. You might be angry at God, question your basic beliefs, and be irritable. And I think that this is absolutely accurate. These are all possible signals of a stress reaction. But to provide this list to somebody who's just gone through an ordeal may create some sort of symptom expectancy that would increase the likelihood that they may present with some of these symptoms. So the next thing that I wanted to talk about is the implementation. On the pro-CISM side, the practical evidence is that people like it. People love this intervention, and people were always, when I did it, really thankful. And they felt really good about it afterwards. The business is continuing to grow. It's a low-cost intervention, and people feel a responsibility to react. Like something horrible happened, shouldn't we do something? That makes me actually think of one that I did after a robbery. And the bank owner was just so broken up, like, or manager, bank manager, that, what can I do to help my staff? But they've been through this because they work for me. And so people want to do something. There's not really a proven alternative. We'll talk a little more about that at the end. And also there's fear of litigation. So there was the Royal Marines versus the British government as an example, but others fear that. What if I manage EMTs? What if I manage firefighters and I don't provide them something? Well, I know I'm sending them into a traumatic situation. On the other side, the faith validity is in question for this intervention. We know satisfaction does not equal efficacy. So just because people like it doesn't mean it's helping, doesn't mean it works. It's presented under the pretense that the experts know that this helps. So everybody who's there usually thinks this is definitely the right thing to do. They're not typically aware that there is an argument or a debate over it. It's an intervention that's applied to everyone, even though most people will not develop PTSD. And of those who do, half of them will have symptom remission in 3 months. But still, we're treating everyone. And I shouldn't say treating, it's an intervention, not a treatment per se. And lots of former practitioners have stopped doing it around the world. Lots of international critical incident stress organizations in different countries have decided not to use this anymore. And then there's this question of psychological first aid, which the Cochrane review said this is an alternative. You can use psychological first aid. Psychological first aid and critical incident stress management are really quite similar. Some people will say the difference is with psychological first aid, it is an identify or assess and treat model only to treat those that need it. But if you read even the oldest critical incident stress management literature, they call it psychological first aid or emotional first aid, and they say we should assess who we need to do this intervention for. So it's very muddy. The research methodology is another point of contention. The pro-CISM people will say, first of all, there's an issue. We don't usually have baseline symptom assessment. It's hard to know who explains to have a trauma, so we don't know how they're functioning beforehand. And in one of the most famous studies by CISM, 1997, it's a study of using burn victims in a hospital where they did randomly assignments to CISD or not. It was what my friend Andrea said last we'll call an unhappy random sample, where the baseline symptoms were much higher in the treatment group than in the non-treatment group. So they have a legitimate criticism of that study. The other issue is hard to conduct trauma research after a trauma to go into somewhere and say we want to now collect data and talk to everyone. People are not in a place to want to do that. And a really common argument is that it's unethical to withhold the treatment or the intervention. And this one sort of bothers me because it presupposes that it's good. So they say, well, how could something, if you imagine if something terrible happened at your workplace, though, or at your school, or somewhere that you are, and your boss said, well, we're going to do research and we're going to give half the people this intervention, and the rest will not get it, or maybe they'll get it in a few months. It just doesn't sit well with people, even though we're not sure how effective the intervention is. But they do say we need these randomized control trials, and they've been calling for them back and forth in their arguments on both sides for 30 years, but there have been very few. The findings on this side, there really is no support that this intervention prevents PTSD, and these folks would say the studies that we do have aren't rigorous, they're not empirical, there aren't controls, there's not the randomization that's needed. This is my favorite part of the argument around fidelity and adaptation. So the pro-CISM people would say that the studies that are showing this is ineffective are not doing critical incident stress debriefing because they're not having complete fidelity to the model. So they're saying, you're testing something else. You didn't do it right. And this is really valid, and we know this is nurse-family partnerships, for instance, which shows great outcomes for young mothers, and then there are other homes visiting nurse programs that don't. So they have a valid argument there because there are many brands of psychological debriefing. The other thing is they say critical incident stress debriefing is not indicated for the sample. Again, with that Vision 1997 study that was sort of scathingly against critical incident stress debriefing, it was done with burn victims. And after that, they said, well, we never said you could do this with burn victims. But in reality, the early literature seems to say it's really generalizable. And when studies come out that say it's not working, they say, well, we didn't mean for those people. And they also criticize that people implementing it are mixing up critical incident stress debriefing with therapy or with treatment. And that, I think, is a really valid criticism, and I've seen it happen. And if you have a therapist conducting a session who has all sorts of experience and sort of an art at their fingertips of what they want to do, it's hard to keep fidelity to this intervention when you're thinking somebody needs something else that you might be able to help them with. So I think it's a really valid criticism. They also say that we're not measuring the correct outcomes. There's too much focus on the PTSD symptomatology. Maybe we should look at group cohesion. Definitely talking about processing a trauma after it happens for first responders and they have to go back out seems to help them as a group to function. What about positive feelings about the intervention? Or what about a decline in substance use, which is something that they found? And then this last thing is critical incident stress management as psychological first aid, which I already addressed. They've been using that term since before this new psychological first aid came out, and that just sort of muddies the water of what we're evaluating, which brings me to this, that critical incident stress debriefing is a moving target. The terms keep evolving. We're not always sure what intervention we're evaluating. And the settings have generalized who this is for. It could be for a school, it could be for a law firm, it could be for a bank. The traumas are generalized. It could be for rape crisis, it could be for an earthquake, it could be for all sorts of things. The core components really require testing. And there's a really great study by Richards, I think, in 2001 that demonstrates this core component issue. They found really positive effects from critical incident stress debriefing. But on the front end of it, there was a pre-trauma intervention, and then there was critical incident stress debriefing, and then there was cognitive behavioral intervention. And then they said, yay, critical incident stress debriefing works. But we know the cognitive behavioral component does a lot to ameliorate PTSD symptoms. So if we don't look at this component by component, we don't know which part of it is really working. And it may have helped, but we can't tell from that study. And another criticism is that it may be mandatory or coercive, as it was with the New York police personnel. And so mandating people to sit in on a treatment that or an intervention they're not interested in can be a big problem. So the meta-analysis that Everly and Mitchell did in 2002, they evaluated 8 studies. This is the one by which they said, see, critical incident stress management is helpful. And they used, in 6 of the 8 studies, the dependent variable they used was that in a hospital situation, staff assaults were reduced. Patient on staff assault. So they said, isn't this a great therapy? Look what we've done. And that's a dependent variable that I didn't even know was of interest until I read their meta-analysis. Also, some of the studies use critical incident stress management for PTSD treatment rather than for prevention. And none of those studies had a control group. And this is a huge issue because we know that in 3 months, half the people's symptoms will reach full remission. So we need to have a control group when we do these studies because time in and of itself helps. Regarding a review of the body of literature, Mitchell has called the Cochrane reviews a hostile inspection process, and he says that they're biased. And this comes back to that issue with Simon Leslie, who was initially, he says, tasked with taking down this intervention. The next criticism, I think, is the most valid. They see there's a lack of clinical meaningfulness in statistically significant results. This is a criticism of all clinical research that was made by Alan Tasden in 2008. And what's behind it is this idea that when we look at the internal validity, when we are so concerned about the internal validity of the study, we may not be capturing any sort of real-world difference. So if my study shows that these people had 8 PTSD symptoms and these people had 13, are these people really doing better? Is their life better? Is their love and work and everything better? Or is it not really all that different even though we have a statistically significant difference? And so I think that's one of the most valid criticisms. And because of that, they say that the Cochrane review is a problem because it favors randomized controlled trials over naturalistic or other types of evidence. On this side, we would say, well, that it's necessary to have a systematic review of the body of literature because otherwise we could have a false positive. We could have a type 1 error that this looks like it helps, but really it was just due to error and just so happened in this one case. So the evidence overall, the preponderance of the evidence is that psychological debriefing is not really effective. There's some studies that show it may be harmful. And the core components don't seem to be particularly effective, although there's really limited research there, and there really needs to be more. The last part of this is the dissemination piece. The International Critical Incident Stress Foundation is a website and a foundation, an organization that does trainings and promotes critical incident stress management. The International Journal of Emergency Mental Health is one place where a lot of the articles supporting this intervention are published, and also in trade journals for EMTs or firefighters and that sort of thing. I think it's really unique that Mitchell addressed a need that he saw from his own life as an EMT. But it's unfortunate that it's such a small group of researchers that are really investigating the efficacy of the intervention. They do think it's necessary to market it, to make it available to people, because they really firmly believe in it. And in one interview, Mitchell actually said that like mesmer and hypnosis, one day all of us will see that he was correct. But we need the research to see that, to see ever will. On the other side, all of the publications against this intervention are in academic journals and Cochrane review. So people who are buying this intervention don't always even know there's any controversy at all, because they're not reading academic journals, and they don't know what the Cochrane group does. They're just seeing that side of it. The other issues around the dissemination are that it is one small group of researchers' viewpoint. From 1999 to 2009, I looked at the International Journal of Emergency Mental Health, and 25% of all of the articles, not counting editorials or book reviews, in there were by 3 authors. So that's an issue about this small group of researchers. These authors are the founders of the International Critical Incident Stress Foundation. They are the founders of the International Journal of Emergency Mental Health. They're the editors of the journal, or are no longer. They own Chevron Press, which publishes all the books about this and the journal. And they own the organization that sells it. And they will say that they're very passionate about it. And I wouldn't say anything beyond that, except it appears to be a conflict of interest, but it may not be. So from there, back to his model, I just put numbers here as sort of how it went. So Mitchell was practicing, and then he said, wait, what's happening? We have a problem. And then back to practicing, and then, wait, there's already been research done, but let's look at this. What's the research on trauma? What's the research on stress? What could we possibly do? And then they went through, what works? We'll create a preventative intervention. And back to practice, and then immediately to, how do we disseminate it? Let's get it out there for the whole world. And back to practice. And I think right here, what works is where this intervention is centering, because we're still arguing about whether or not it's actually effective. So lastly, I just want to say, I think this is really an interesting case study of research and science at odds, rather than informing one another. It's a long-running debate. Both sides have accused each other of impropriety, and in some of the interviews, they actually get downright nasty to each other. It's not always professional. But I think both sides are really genuinely interested in helping victims and believe in what they're doing. I don't think this critical incident stress management, this is not a case study in what intervention to use or not to use, and it's definitely not a case study in how to do translational research. Case study in why we need translational research, because these two groups need to be talking to each other. Yes.
I really enjoyed this. I knew nothing about it, and I love your presentation. So, say in your next venture, you're back being a clinician, and you're faced with some trauma victims. Would you see them?
I don't think I was, but I wouldn't say that I necessarily think it's bad. I do believe a lot of their criticisms are valid. I think there just needs to be, the research isn't there to prove it's effective, and it should be there before we do it. And I feel like when the Cochrane reviews happened, when the National Institute of Mental Health came out and said don't do this, they didn't say, we know it's bad. They said, it might be bad, so let's not do this right now. I think there just needs to be more investigation, because it seems to me also that, having worked at a crisis center where I encountered crises daily and saw traumatic things, as soon as we come back, we wanted to talk. We wanted to process this amongst ourselves. So that seems a healthy thing. We need to understand the core components. What are the parts of this that are good, and what are the parts that are not good?
And that was why I asked you the question, because you had experienced it, and yet now the research is saying this isn't good, and that's sort of conflicting with what you actually. So anyhow, I was sitting there thinking about that.
Thank you. Yeah. Before I went to based on your experience, not knowing that the research kind of was what was your experience? Yes, I did do it. People loved it. People felt so helped. People felt like they came together. So before we heard it was really when the National Institute of Mental Health came out and said, don't do this, we were like, what's that about? And also the military stopped using it at that point. So before that, we didn't go there again controversy. Yes?
I'm trained here. Critically, but I used to be given that right after 9/11. I think that one of the things that happens to everybody, and then to generalized activity, universalized activity, is that we feel out of control. And what this does is it gives practitioners a sense of control about what to do.
and it gives organizations a sense of control, like the site manager, on what we can do that will be helpful. And that has value. At the same time, the idea that we're handing out those forms, when I first saw that, I was appalled, because it not only pathologizes but predicts. And so much of how people respond to anything is based on other people's reactions and expectations, as well as their own. And that can be really detrimental. And that's one of the things I don't like about the way that people sometimes carry out the world.
I agree with you, and that's sort of what I'm talking about, investigating these core components. Sometimes if we just took that away, these things would be better. But it does bother me that on their website, that's still right there. And we know today, for people after something happens, that might be what they find first. They might be home searching and find that. And that might not be particularly helpful to them at the moment.
And there are people able to go to the differential, or they look at their differential expectations, so like then you're or something that's an
Not a problem.
Not that no, but that's the type of thing that needs to be investigated. And also, I mean, there's a lot of theorizing that maybe for a large proportion of people this would be a healthy intervention, but for some people it may not be.
Another factor that's off that is there is a lot of people who go back into the field. And I think there's a big difference between people who go back into the environment and experiences that may be very difficult to deal with, as opposed to people who experience something once and then return to their more normal, typical life.
And I agree, but I will say that even in the early literature by the creators of the intervention, they really say it can be used really broadly. So they didn't put that restriction. They weren't conservative in that way. I think they've become more conservative in that way over time because of the criticism. But that may be a part of the reason for the debate.
So they're saying it's more useful for people to go back into it, or less useful for them?
We don't know because that research hasn't been done, but the idea is that it was initially created for first responders, for EMTs, for soldiers. Yeah.
Having been doing a lot of work on this was all going on, it was so interesting because it was all about timing. Because all these things were happening on the international, and these folks were developing a specific model that time was just this is how I thought. And then afterwards it was like, oh, we're doing this for population.
I think that the providers, and myself included, got caught up also in the we need to do something. And look, we could do this.
And there was a lot of money. Yeah. There was a lot of money to be made. You could say we have this model to come in here in school after a shooting and help us. Right, yeah.
There's also the first responders, and just a personal experience, and with a kid firefighter, and was on the Pentagon roof. Everything about their natural systems was just kind of melted away. If they could get critical debriefing, then you really didn't have to have the supervisor talk as much. There really wasn't a whole lot of other stuff kind of going on. And the fact is also, a lot of these guys who still hold the anger about that, because you hear them, is they were never sane. So I guess my point is there's just some natural things that happen in these guys' systems that sometimes get supplanted because people think that this is probably the cure-all. But really what it does is it separates people from their own natural support system.
Yeah. A much more macro question. I got caught up at the beginning of your talk. Do you know what we know about people who don't suffer PTSD after an event where PTSD happens, like people who are really close to something phenomenal traumatic? study of those books.
Oh my God, taking a page, you can ask for it.
It's just the focus really was just so much on PTSD, but they weren't looking at the person. Who was in the control. And that's work that really has very much involved in the last 8 years.
So for those situations, I would expect control in some ways to be the PTSD for people with PTSD, and that's a more natural response to trauma, but the people who really don't respond to it. Yeah, I believe that.
More depending on the situation.
Really, even if really complicated, we want you to sign a fire or anything like that. This is not, that's what we should be studying.
I want to know a little bit about why the military, what they're doing instead of.
Yes.
Part of the reason we move away from it is because it's actually a commercial product, and because they're kind of start getting into it right now. I don't know if the military knows that it's a lot. They don't call it, you do a scan, so what you're doing is a lot of these studies now on suicide answer the question of why do some people who've all been in traumatic situations evolve for suicidal or suicide. And they look at what kind of debriefing is taken. So that it's a very interesting process of directly to form big PTSD studies. This is not very long. They're looking at some of the things. And I know that it's a very specialized population, but presumably it will inform other people. But another thing that is very article is also a lecture on PTSD and why anybody can have discussions of the current funded studies, which may be look at many parallel.
Thank you. I would like to talk to you more about that. Actually, right before giving this talk, I was looking and saw something saying they were using debriefing again, even though I knew that they weren't, and I just had to
They're using debriefing, but they're not using
that model.
Yes. Yeah. And they do what they call that, but that's very interesting idea. And when you think about it, when people come back from the war, especially Second World War, Korea, they didn't leave the combat zone. Come out, have 2 days to get cleaned up, pack your bags, and get on the plane and show up there and take up to the border for, Lexington, Kentucky. They were like my dad and my brothers. They got on the ship with their units, right? And they sailed back. So they already had debriefing among their members. So they're saying not everybody shows the symptoms. That would be a lovely study. Right. Look at the people who slowly came back, met people who experienced the trauma, like first responders, had time to talk about it, or in a safe environment, and slowly reintegrated back into whatever the norm was for them. And the percentage of people who then had those kinds of skills a little bit away from that, but not too much now. There's one minute you're going to be children, they're there, and they kept going for the party, and we're having cake. So what if it's going to die?
I've also wondered sometimes whether the nature of warfare over the past 200 years has changed substantially. And conditions are different. Warfare for this time.
Or in some cases even further for people using technology who are distanced from what they've done.
Right, the guys that are flying the drones,
right.
For example, I think there's some information that's starting to come out of this responses that people have to the post-traumatic memory, I should say.
Yep.
Thank you so much. It was really interesting, and I'm sure everyone wants to come up